We shall now go on to our next speaker and last speaker, and we look forward to a great talk from you, Dr. Parveen. And she's a senior consultant at the Vitreoretinal Department at Shankar Nethralaya, Chennai. And she is going to tell us about correlation between OCTA and multifocal ERG, the clinical applications. On to you, Dr. Parveen.
Thank you, Dr. Chitra, for the invitation. I'll just start with my... So after a very good talk by Dr. Barbara, I think I'm going on to a very niche topic, which I'm not sure how many would really find it very interesting. I'll try to keep it as interesting as possible. So this is how do we correlate the OCTA, which we have heard about the whole evening, and correlate it with multifocal ERG. So why are we interested in correlating these two investigations? What is the similarity? So both of them are non-invasive. OCTA also allows the depth resolved images of retina, and the MFERG is also giving us the functional dissection of the retina. Both of them are objective evaluation of the retina. Both are useful in the early stages of the disease and useful to assess progression of disease. Here is the difference where OCTA gives us the structural analysis, whereas the ERG is giving us the functional analysis. The major application of comparison of OCTA with MFERG has been in diabetic retinopathy. And this has been an enigma, especially lately. A lot of discussion has been on this, that whether diabetic retinopathy is a microvascular disease or is it a neurodegenerative disease. So retina is definitely a part of the brain, and the word retina itself means a network. So only 5% of the retina is made up by the blood vessels. So if the diabetic retinopathy process was to involve the whole of retina, and if it was only involving the blood vessels, only 5% of the retina would be involved, which cannot be possible. So we are still, whether it is a microvasculopathy or is it a neurodegenerative disease. And if it is primarily a neurodegenerative disease, then it can be best assessed by a electrophysiological technique. The various electrophysiological techniques which are available to us, but we are going to talk more of multifocal ERG today. But before I go on to that, diabetic retinopathy can affect the full field ERG itself, and the scotopic responses are more affected. Implicit times can get prolonged, decrease in amplitudes are seen even on a full field ERG, even in cases with mild retinopathy, and increased IT and decreased amplitude of photopic 30 Hz flicker responses also reflect that it is a cone dysfunction and not only the rod dysfunction. Rods are more affected than cones because of the high metabolic rate of rods, and hypoxia in the retina is most pronounced in the dark adapted state. So amazingly, few studies have come that if you sleep with lights on, you can actually reduce the hypoxic state and probably prevent diabetic retinopathy. So multifocal ERG, you can see that in normal subjects, these are the good normal responses. In patients without DR also, there is already a reduction in the responses. In diabetic patients with early DR, it's almost like a squiggle. And in diabetic retinopathy with late stages of disease, it is absolutely non-recordable. Especially in these areas which have the exudates and cotton wool spots, these can be particularly more depressed responses on multifocal ERG. And if it is edema, it depresses the responses even further. What happens on OCTA? In OCTA, the typical findings which are seen on DR include thinning of the RNFL or the GCC, and there is increased foveolae vascular zone. There is a decrease in the vessel density, both in the superficial and deep fluxes. And we have seen in the previous talks by the speakers on the quantitative analysis, and all these things can be assessed non-invasively. We did a study where we did try to compare the OCTA findings in patients with no diabetic retinopathy and compare them with the ERG. And we saw that definitely this vessel density in the superficial and deep fluxes was reduced, and this reduced progressively as the degree of severity of disease increased. You can see we did speak of the FAZ parameters. There is decrease in the increased size of the FAZ as well as increased irregularity and the circularity indices. All these can be hampered with the progression of disease. So a comparison of OCTA and ERG helps us to uh, compare the morphological and the functional parameters. And we have seen that wherever there is a decrease in the vessel density, it corresponds with the B wave amplitudes. And this is a nice paper from Shankar Nethralaya again. And it shows that decrease in the vessel density as seen in the superficial and deep fluxes corresponded very well with the decrease in the responses on multifocal ERG. And this is the graph which shows the same. There has been a nice study, the Eurocondor study, which has looked at the functional and structural parameters, but they have also mentioned that it is not necessary that the microvascular lesions and MFERG always go hand in hand. In fact, they said that 61% of patients without visible microvascular changes could have neurodegenerative changes, and they said this could be a new neurodegenerative phenotype of diabetic retinopathy, while 32% did not have any abnormalities on MFERG, but had abnormalities on OCT, and this could be primarily a microangiopathic phenotype. So, as I did mention, multifocal ERG comes mostly from the outer retina, but it is the inner retinal ganglion cells which are supposed to be more sensitive to the damage by high glycosylated hemoglobin or glucose levels. There's another parameter called the photopic negative response, which can be even more susceptible to changes in the diabetes glucose levels, and this gives us a full field response. So this can be sometimes more sensitive. Going to some of the other diseases where these two can be relevant, one is retinitis pigmentosa, which again presents with decrease in the superficial and deep capillary fluxes. And here again, the correlation has been seen with the parameters on multifocal ERG, especially the P1 amplitude in the ring 2. The parafoveal area has more significant loss and more associated with a decreased density of superficial and deep fluxes. This is an example. You can see this is a patient of retinitis pigmentosa, and the central area appears to be spread, which is why the patient still has good useful vision, and this can be very beautifully seen on an Optos picture on autofluorescence. And when we do the ERG, it shows it is almost completely extinguished. Multifocal ERG shows central island of vision which is preserved. You can see preservation of the ellipsoid on a structural B scan. On an OCTA, you can see superficial fluxes is reduced, vessel density, especially in the area which is just beyond the arcades, which corresponds to the area where there was reduced autofluorescence, and also deep fluxes shows a decreased vessel density. So there have been publications. They have also mentioned the same thing, that enlargement of the FSZ and reduced vessel density corresponds to the area of reduced amplitudes on multifocal ERG. Similar thing in Stargardt's, we have decreased superficial and deep fluxes vessel density. Plus, in addition to this, the choriocapillaris also shows a reduced density because of the reduced blood supply in the choriocapillaris. And we know these flow deficits in the CC in Stargardt's are much more than that what we see even in the AMD. So why is there a decrease in vessel density in inherited retinal diseases? And there have been two theories where they say that it could start with a vascular depletion, which causes RP degeneration. And because there is RP degeneration, there is modification of the VEGF concentration. And this then reduced demand because of the atrophy leads to reduced blood supply. But vice versa can also be true, that because of the reduced blood supply, because of which there is a reduced vessel density, and this is causing the RP degeneration. So there is more stress on the pathogenesis of disease, and we are understanding it better with the new imaging techniques. So this is helping us understand the disease in a much better way. And of course, Opta can help us rule out any underlying CNVM, which can be present in any of the inherited retinal disorders. You can see this is an example of Best disease, where the patient was actually received some anti-VEGF injections intravitreal outside, though this is a typical case of a Best vitelliform disorder. You can see on an OCT as well, but probably this is what was thought to be a CNV, but when you do a OCT angiography, you do not pick up any CNVM, and this is just a hypospace below the vitelliform lesion. And ERG, of course, puts the diagnosis in place with reduced EOG. In HCQ toxicity as well, which is not, which is an acquired form of disease, the reduced vessel density has been seen. And amazingly, they have divided these cases into two groups where there is reduced multifocal responses as well as normal multifocal responses. And they have seen that the vessel density is remarkably reduced when there is abnormal multifocal ERG in patients with hydroxychloroquine toxicity. So even in the presence of a normal structural SDOCT. So as you would know that SDOCT actually forms one of the most important parameters where we have has been advised as a screening tool, but as OCTA can even be more sensitive. This is an example of a patient who was on HCQ for a long time. You can see that though the vision is almost preserved, you can already see that multifocal responses are slightly less, especially in the central two rings. Ellipsoid is okay, SDOCT almost looks all right. You don't have the inverted saucer shaped sign. And here the OCTA, the vessel density almost looks fine. It is not too affected, but multifocal ERG has been able to pick up the reduced responses even early on. So in conclusion, it helps us to look at the functional as well as the structural changes and correlate them for better understanding and pathogenesis of disease. And of course, to rule out the presence of CNV in the IRDs. Thank you for the talk. And once again, thank you for the invitation and to participate in such a good discussion and topics. Thank you.
Thank you very much. That was a very crisp talk. And Dr. Jatinder, would you take a question?
Excellent last two talks, Dr. Barbara and Dr. Parveen. Thank you so much. Very nicely put up. Dr. Parveen, just two questions. How often do you see choriocapillaries, loss of choriocapillary densities in macrodystrophies? Second, in occult macular dystrophy, do you have like evidence that there is choriocapillary ischemia? Because if even before the multifocal ERG affected, or the prognostic follow-up of those patients?
So actually in inherited retinal dystrophies, I would say functional aspect is definitely more important than you could pick it up structurally. And sometimes in presence of macular dystrophies, it will be difficult to evaluate the CCFDs or the capillary flow deficits because of the large amount of shadowing and scattering which we had. But we did assess CCFT interestingly in a very good paper which we have published recently also. It was that we had tried to look at CCFT in eyes, in the fellow eyes of PCV patients. And we found that the CCFD was increased even in the asymptomatic eyes when the other eye had PCV manifestations. So definitely there, I would say it can be of prognostic value, and probably it could show us that we need to follow up these patients well. But it is still a lot of work is going on. Probably Jay also would have done some work on it, and he would like to add something more to it.
Srinivas, you have anything to ask before we conclude?
No, madam, I think it's good to go. Thank you.
So I think I would like to
thank everyone.
Fantastic talks. Beautiful.
Fantastic talks. Each and every one of you have put up excellent efforts, great talks, right from Padmaja, Anand, Upsham, Dr. Divyansh, Pradeep. Thank you so much for putting up such a great show. Thank you.
This was a very wonderful session, and I truly have to thank my expert panel for being there right till the end. And such a great joy to see all of you here on the screen, and fantastic set of speakers. Thank you so much, each and every one of you, for making our ARC meeting such a star evening today. My very special thanks to Srinivas as always, and a lot of thanks to Jatinder too. And I do have to tell you that this Jatinder, I asked him to just put this program together, and I mean the topics, and I never thought for a moment that I would enjoy this so much as I did today. Thank you so much, Jatinder, for being there with us. My very special thanks to my ARC team, who are always there encouraging us to keep going forward. And again, our thanks are due to Kripal and Aios admin for all those SMSs which they send and their support in the background at all times. Thanks to Sai and Manjula from Numerotech for all those emails which bombard your inbox. And most importantly, I want to warmly welcome Mr. Sunil, who is the webinar admin. He was with us the first year, not in the second year. And I'm sure he'll bring in a lot more energy to all our webinars. Thank you very much, Mr. Sunil, for being there. I hope you're there. I think you are missing for a bit in between. Thank you again to all the delegates who have watched this meeting. And I'm sure if you have watched, you have learned a lot. Thank you very much, one and all of you. Thanks.
Thank you, Chitra, for a wonderful, wonderful webinar. Thank you.
Thank you.
Thank you, everyone.
Thank you. Thanks a lot.
Yeah.
Fantastic.